We can't use words like treat, mitigate, prevent, or cure disease when we talk about dietary supplements. That's strictly forbidden by the FDA rules and laws. And so you have to really focus on function. So when people talk about dietary supplements or natural products and they talk about treating diseases, I always wince and I say, a more appropriate way to talk about that is, how am I using this dietary ingredient or this medicinal plant to change the function of the body?
I'm Lloyd Finks, MD.
And I'm pharmacist Dr. Shannon Finks.
Welcome to the ZUP podcast. Here we take an intentionally different approach to the practice of medicine.
That's why our podcast is all about answering your burning questions and challenging the status quo in the healthcare industry.
Right. All while making medical information digestible and accessible for everyone. You ready to stir the pot?
Let's get cooking. So Lloyd, you are wearing scrubs today?
I am. It's blistering hot outside, and scrubs are the only excuse a man my age has of wearing his pajamas all day long. Oh. And I'm staying cool.
All right.
Yeah. I missed the invite.
You could have, you're a big boy. You could have made your own decisions. Yep.
All right. Well, I'm glad you're staying cool.
Thank you very much. I'm also brought this.
Yes, and you're going to be the class clown.
I'm not.
I'm introducing my friend and colleague, Dr. Ryan Yates. Ryan is PharmD PhD, and Ryan and I have known each other for probably 30 plus years.
Almost 30 years.
And I brought Ryan in today specifically because of his expertise and to talk about his journey in the scientific drug development world and the jump that he's made to what he's doing now. And it kind of co-aligns.
Co-aligns. That's a good one.
Yeah, thanks.
I like that.
Thanks.
Yeah.
It co-aligns with what patients want and what we're trying to do differently at ZUP. And so I would love to just ask Ryan to tell us a little bit about yourself and where in a brief synopsis so that we have lots of time to talk about what you're currently doing and what interests us, where you've been and how you decided to do what you do now.
So first, thank you very much for having me. This is going to be an absolute treat for me. Been looking forward to this.
I have the need to blow the horn.
Take you way back. It's almost 50 years ago. I first worked in a community pharmacy in a small town in Kentucky, and I imagined it was much like when Tiger Woods picked up a golf club for the first time, that it was like, oh, this is what I was meant to do.
Mm-hmm.
So twists and turns, right? Life happens. I spent, many years in the U.S. Navy riding submarines, running nuclear reactors, and then after that came back to pharmacy school.
So were you already a PhD? Or you?
No, this was all out of high school.
Okay,
so,
wow.
So yeah, no education. That's a whole other story, at Charleston, Citadel, and going to night school. Anyway, but then I got out, went to undergrad in Knoxville. I ended up in Knoxville because I thought the pharmacy school was in Knoxville. Okay, so I show up in Knoxville. So I get my discharge papers from the Navy in Charleston, South Carolina. I drive to Knoxville overnight, stay in the old Frost Inn. Remember, they were on I-40 just this side of Knoxville. And I show up in the registrar's office the next day and I said, my name's Ryan Yates and I want to go to school here. And they were like, wait a minute, that's not how this works, right? And they're like, so fortunately, as a veteran, they bent over backwards, got me housing, got me in school, and did my pre-pharmacy degree in like 18 months.
Awesome.
And that's where I met my lovely wife, Mary, who is also a pharmacist. And then we applied to pharmacy school. Got our letters the same day, same class, the whole 9 yards, moved to Memphis, and then that's where sort of everything started. So for me, I had always had the retail experience, a little bit at least in the early days and then while I was an undergraduate, and I always knew that despite the love of pharmacy, I wanted to do something a little different. And fortunately, we had a visionary dean, Dick Gorley, just a giant of a man, and he had started this program called the PharmD PhD program. So you could do your pharmacy degree and your PhD degree at the same time.
So the difference between a PharmD and a PhD there's a lot of difference. So maybe tell the
Right. So pharmacy, as you can imagine, you learn all about drugs and how to teach people about drugs, and then work with your healthcare colleagues, physicians, nurses, et cetera. So that's the pharmacy side of it. A lot more than what most people see every day about pharmacy. The other part of that, in the summertime and in the evenings, I would spend in a research laboratory. So one of the first laboratory experiences I had there at UT was working in the lab of a guy named James Dalton, who is, I guess his claim to fame, he and my other professor, Dwayne Miller, their claim to fame is literal discovery of selective androgen receptor modulators, what we know as SARMs.
Why are you blowing?
I'm blowing because I'm going to try to keep you guys focused on speaking to somebody like me.
That doesn't understand drug development.
But I was bringing it back. You
would have to bring it way back. You would have to row for a day and a half to bring it all the way back.
But it's really important to the story.
Okay, all right.
Trust me.
I'm going to leave it at SARMs, but I want everybody to understand that I have no idea what you're talking about.
So whenever you're ready to go back, Goss.
I'm ready.
All right. Okay. So SARMs is simply a muscle-building agent, much like steroids, that don't have the negative effects that you see with steroids, the big muscle-bound guys and the problems that they have with steroids. So bottom line, that led to a company, and so I got a lot of experience in drug development. And as part of that journey, I worked at St. Jude Children's Research Hospital when I was in pharmacy school, and I got a chance to work in a laboratory where we were looking at the genetic basis for a drug toxicity for a drug for children with leukemia. So about 1 in 300 kids can't take standard doses of this leukemia drug. And by not tolerate, I mean life-threatening cardiotoxicity. So we were locked in a battle.
Cardiotoxicity.
Sorry, your heart problems. So things start to go awry, right? And I think the audience knows that when your heart goes, that's pretty much it, okay? It's a life-threatening problem with your heart when you take the standard dose of this medicine for leukemia, and it's based upon your genetics. So not frequent, but still a personalized approach. And so we were locked in a battle with Mayo to discover what was the genetic basis for this metabolism, this inability to eliminate this drug, and then as a result have toxicity. And so I stumbled one night in the laboratory, I did an experiment, I stumbled upon the genetic basis, which then allowed us to develop a test that was specific for that anomaly for children. So that led to my first publication and led to this really passion for genetics and pharmacology and pharmacy. And so I was really sort of running this parallel path between what we call pharmacogenetics, or genetic basis for pharmacy response, and the drug development, drug discovery. And so I sort of, as I finished my pharmacy degree, I went into the PhD side, went back into the laboratory that had discovered these muscle-building agents, okay, these SARMs, and so was just continued that drug development, because that was what I'll call an academic drug discovery. So the idea is to develop new drugs in an academic setting and ultimately introduce that into pharmaceutical companies. And so pharmaceutical companies often use that as a pathway or a pipeline to develop new drugs. So there's a lot of, obviously, academic and research and interest in this space. And so fast forward, finished my PhD, stayed at the University of Tennessee, and started my research laboratory there. So this was back in 2000. So about 2015, 2016, pursuing this, what I'll call a normal path of drug discovery, the pharmaceutical approach, I ran into my PhD advisor again, Jim Dalton. So this is now 20 years plus years after discovery of these muscle building agents. And I asked him how things were going. He said, well, we're still in clinical trials. Okay, so now 25 years later, still in clinical trials. So that was the epiphany for me. That was the aha moment. I said, if I'm going to have an impact, I better do something a little different, trying to get something into the marketplace. Well, fortunately about that time, I was introduced to an absolutely brilliant dude at Oak Ridge National Lab. And this guy, Rangan Sukumar, he was a data analytics guy and an expert in artificial intelligence, back before artificial intelligence was artificial intelligence. So this is circa 2016. And so I read a story about him in the LA Times. I literally got in my car, Memphis, I drove to Oak Ridge, and I said, "You don't know who I am?" I said, "But I read this article about you, and I'm fascinated with, this artificial intelligence and how we can use that for drug development and disease and discovering things." And I said, "I just want to use your system." And he's got this big infectious smile and laugh, and he hands me a PDF and he goes, "Here's the web address and here's a PDF." He said, "Go for it." Okay. So long story short, that started me on the journey, which has culminated recently in a supplement that I have developed. So the basis for that is, in the cardiovascular world, heart problems, we have statins. Everybody's heard of statins. One of the gaps left by statins is they don't cover about 75% of that risk. And so Shannon can lecture on this, much more eloquently than I. But as I understand it, that residual cardiovascular risk is related to things that are associated with the fats that our liver produces. We've all heard the term triglycerides, something you see on a standard lipid panel. And so the approach, since I was in pharmacy school and before, and unfortunately still today, is taught that we use fish oil. We call them omega-3s, but sometimes they work, sometimes they don't. Unfortunately, more times don't than do. And so if you're trying to individualize your patient's response to these omega-3s, you got to really know how they work. And so that's me. I'm a systems guy. Everything is connected. And so I asked the question, right? This is now going back to pharmacy school. Okay, great. This fish oil lowers these fats that the liver produces. How does it do it? We don't know. Well, what do you mean we don't know? Like I always told students afterwards when I was teaching, I said, every drug has two mechanisms of action, the one we know and the one we don't know. This didn't have a mechanism that we knew. So this artificial intelligence led me down a path where it identified a specific set of sequences in the liver, right? In my humble opinion, the body's most important organ. We can talk about that ad nauseum. But the liver and how the liver has to use dietary ingredients, other things we eat besides fish, which contain those omega-3s, those fatty fish anyway, and convert it into an active form. And so what I tell people is that you can take as much fish oil as you want, and you're very unlikely to receive any of the positive benefits if you don't have the other ingredients that your liver needs to go along with it. It's like building a house. You don't have bricks, you don't have boards, you don't have you have all those things that go into making the house. And so that was how I developed this supplement with the starting point as this artificial intelligence network. Develop the supplement. And so that's what I've been doing for the last 7 or 8 years, is getting funding for that, doing the animal studies, and then doing the human studies, while at the same time taking a slightly different approach than most supplement makers, which is how do you protect your innovation in a world where everybody's selling echinacea, vitamin A, and vitamin D, and there's really not a lot of protectable material. And so my thesis was, and it bore out in ultimately getting the patent, is how do you take two things in nature that are unconnected, okay, at least in a biomass. I said earlier, right, everything's connected. They are, okay, but not from an obvious standpoint. So just because you find something under the sun, right, to use the Supreme Court's verbiage, okay, is not patentable. But when you put two things together that aren't found in the same plant or biomass, and you show that they act together, synergy, or some people like to say force multiplier, then you can get a patent. And so that was the thesis: develop something that works, develop something that, while working, can also be protected to add value to it, and then you raise money and you develop that to do clinical trials. And we were fortunate to partner with you guys and do our latest open label trial. And so that's where we are today, is in the supplement world, getting it to the patient for very specific needs. But here's where pharmacy comes in. because this is not your standard path. We can't use words like treat, mitigate, prevent, or cure disease when we talk about dietary supplements. That's strictly forbidden by the FDA rules and laws. And so you have to really focus on function. So when people talk about dietary supplements or natural products, and they talk about treating diseases, I always wince and I say, a more appropriate way to talk about that is, how am I using this dietary ingredient or this medicinal plant to change the function of the body? I don't need a disease to change the function of the body. Let's go back to my thesis on the liver and all of the bad effects of a modern Western diet, really high in carbohydrates. We can talk about that, but ultimately what that does is it leads to all that fat clogging up our liver. That doesn't start when you have a disease. That's over many, many years, beginning when you are...
It leads to a disease.
It leads to a disease. And so that's where these interventions can really help patients. And it's that pharmacist or someone working in a unique practice environment like ZüpMed, right, where you have that hand-in-glove interaction with the physician and the pharmacist, that you can explain this to a patient, because this is not the kind of supplement, individualization, that really works well on Amazon.
Right. Let me say a couple things about why I'm so happy to partner with you, and Lloyd can jump in too. But the pharmacogenomics, and even going beyond just a genetic map, if you will, to choose drugs wisely, is great. But we can go beyond that and use nutrigenomics, which is a map of our DNA and how we process, or how our enzymes function, and what sets us up at risk for certain deficiencies. And you talk about building this house, you talk about needing your bricks and your mortar and your nails. We can learn so much about health in this day and age, and it happens to be 2025 right now, by utilizing some genetic tests to help us individualize therapies, not therapies that treat a disease, but supplements, nutrition, food, pharmaceuticals that actually help support health. And that's so interesting to me. And I know that you're interested in that too. And that, I think, is a future where our healthcare should be going.
Can I interrupt though for a second? And let me just preface this by saying I've never been more fascinated with a guest and to hear all of this. But I also don't think I'm going to be needing this because I think you're both doing an extraordinarily good job of keeping it geek free. But in your run there, there's so much to think about. But one of the things still bothers me, and that is the difference between what is a supplement and what is an approved medication. And it really bothers me because I mean we have so many plant or naturally derived drugs that are approved for treating, mitigating, preventing, whatever words you used, disease, that are FDA approved to make those claims. And then we have supplements. And I think there's a great deal of distrust among the public about what are these supplements? What are these things that don't really qualify to ride on the bus with the big kids? So can you guys help little old me with that?
So that is a great question. I love to continue to educate my colleagues, particularly those in early impressionable years when they're still trying to
That's me.
Learn their craft.
That's me. You just described
I
me.
know, right? I'm
very impressionable.
Yes, and I'm still trying to figure out what I want to do when I grow up.
Right,
too,
right?
But I think that's the key, very seriously, to being inquisitive and growth mindset, and we can talk about the whole philosophy side of it. But I think that's ultimately the key, and those are the people that you want to work with. So it's a curse as well, because I get asked what are some people consider cutting edge technology. And let me give you an example. So I was approached the other day, and he was very interested in this really popular wound healing peptide.
Okay.
So peptides are huge, right? As you guys know.
Yes.
I stopped him and I said, tell me what regulatory framework. Now remember, this is a pharmacist who is a licensed practitioner.
Okay.
That's key. I said, tell me what regulatory framework you're following for this peptide. He goes, what do you mean? I said, is it an approved drug? He said, no. I said, is it an unapproved drug that's on the FDA's bulk drug substance list for compounding? No. Is it a dietary supplement? No. I said, if you're outside that scope, then you're not practicing, you're experimenting on people. And two things. One, you're licensed and you should know the difference. Two, that patient better know that you're experimenting on them. Now, that doesn't mean there's not a framework to do that, right? We have investigational drugs and doing research IND. You come up with a brilliant idea and you want to test it. It's not an approved drug. You can go the route to do that. But it follows a pathway where that patient is really informed well and they make an informed decision. So back to your question.
They make a decision on, is this safe enough? Is the risk from this worth the benefit that potentially might occur? But importantly, in investigational situations, really you're keeping that patient safe, or at least that is the more important part of that equation.
It's always been about safety. Whether you're starting with the FDA, the Food, Drug, and Cosmetic Act, it was about safety, the sulfonamide.
Right. But I'm going to remind you of one of the pillars of ZUP, and that is safety, patient safety. In fact, it is the pillar from which we operate.
Right.
So I have to go back and ask the question. We offer supplements. We offer vitamins. Okay, and I'm very familiar with that you're not allowed to claim that they treat or prevent or cure, mitigate. So what makes that difference? Are you telling me that a medication is simply a supplement that has grown up, that has been properly tested, and has been proven to be efficacious?
So dietary supplements. I'll go back to what's the regulatory framework? If you're going to put something in the dietary supplement framework, regulatory framework, it falls under what's called the Dietary Supplement Health Education Act of 1994. You'll hear it sometimes referred to as the SHE. The SHE spells out what can be a supplement and what cannot be a supplement. Very specifically, if you do not give whatever you're trying to develop as a supplement orally, it is not a nutritional supplement.
It has
Period.
To be given
All
with
stop.
nutrition.
Right. It can't be. Right. So if you want to take a different path, you want to rub it, you want to inject it, you want to do whatever else, you've got to have a different pathway. That is not a dietary supplement. Now, in today's world, we differentiate between old dietary ingredients, meaning things prior to 1994 that were in the food supply. So one of the key ingredients in the supplement I've developed is sesame seed extract. And so sesame seed has been consumed for thousands of years. We got a ton of data, safety data with that ingredient. Another is vitamin B12, same kind of thing. So if it was known and in the food supply before that 1994 stake was placed in the ground, it qualifies as a dietary supplement unless there's a list of toxicities, adverse events, things associated with that natural product, okay? Now, anything after 1994, the FDA says, look, we don't have a lot of information. We get it's natural, but you're going to have to follow what's called a new dietary ingredient because we just don't have the data. We got to generate some safety data, at least in an animal. We've got to ideally test things in humans, but that's not a requirement yet. It stops at the animal testing and other things. And so a supplement, if it's natural and it's been in the food supply, or some medicinal herb, Ayurvedic medicine, ashwagandha, let's use that as an example. For thousands of years, you're good unless there are known toxicities. If it's new, you still have a pathway to develop it as a supplement, but we can't just go out the next day and start putting it in the market and putting it in people's mouths just because it's natural. I think that's the thing where your patients really need to be educated.
Yeah, and Lloyd, we're getting to the answer between a supplement and a drug, but I'd like to say that all natural does not mean all good. And I think that the perception in the general population is that, anyone can buy this without a prescription, so therefore it must be fine, and it must be what the bottle says that it's going to do. And quite frankly, that is not the case because there aren't required clinical trials that mandate a company go through in order to put a bottle with the label on its shelf on Amazon. And the difference between, and I'm going to call out Ryan's supplement because he has gone the extra step to do the clinical trials in humans, showing what we believe is very important. But to go back to answer your question, DSHEA, right, is very different from an FDA approved drug. And I'll let Ryan, since he was in drug development, talk just a little bit about that. But I do feel like it's important to know that for a consumer to understand that, yes, supplements are all natural, but that does not mean all good. That does not mean that it is safe for all humans to ingest, nor does it mean that the claims on the bottle are going to be the individual results of that person who consumes that product. And more importantly, if you are taking a supplement, why you are taking that supplement needs to be discussed with your healthcare provider, because there are so many drug interactions, disease states that may be impacted by some of the ingredients in a natural supplement. And so this is a $5 billion industry where patients believe that this is safer than an FDA-approved medicine. Whatever you put in your mouth, whatever you are consuming, needs to be discussed at your doctor's visit, because there are a lot of implications that need to be hashed out so that you are kept safe and that you are getting the anticipated benefit from whatever drug therapy you're taking.
Okay. So there's a very set, there's a paradigm for developing a drug. It goes through animal testing. It goes through cellular Petri dish toxicity testing. It goes into animal toxicology. It goes into early phase human studies. And then you follow that up with, hey, this looks like it might work. Does it work in a few people? And if that shows promise, then you do a study which leads to ultimately approval or disapproval by the FDA. So it's a very formulaic sort of thing. So that's what I did for a number of years. That's another fascinating story, working with the FDA to develop drugs where you can't recruit for clinical trials. So for example, how do you recruit for a clinical trial for a dirty bomb, high radiation? So there's a whole different pathway for that. So that's very rigorous testing, safety, production as well, in terms of what's in that bottle matches what's on the label, matches time and time again what you prescribe for your patient. If it says 5 milligrams, they're going to get 5 milligrams within a very tight, right? So that is important. Now, I want to tie that to the natural products and supplements. Supplements do not have to go through that rigorous process. So what you will see typically is people will piggyback off of others' research. If you're developing an echinacea or some other vitamin and mineral supplement, you'll either use animal study or somebody else's human studies to do that. Okay? But again, it's not with the same rigor and it's not required. The other part of that is I want to dispel, because I hear all the time, dietary supplements are not regulated by the FDA. False. Full stop. Dietary supplements under DSHEA are regulated by the Food and Drug Administration. The problem is that they have a handful of investigators and it's a multi-billion-dollar industry. So there's a lot of, can I use chicanery? Is that too?
Sure, okay. Great word.
Oh. I don't know tell me what that word means. I don't know what that word means.
Sleight of hand. So let's think about this. Okay. Where's the incentive for the sleight of hand, and where does the pharmacist physician lose out, and particularly the patient lose out on the other end of that funnel? So think about this. You've got and I'm going to use my colleagues in India. They grow sesame seed. That goes to someone who processes sesame seed. That goes to an ingredient supplier who then takes that, sells that to a contract manufacturer there in India that then puts it into a bottle and puts a label on it and then ships it to a brand. We're not going to use brands, but all these brands of natural products. And then that brand sends it to ZüpMed and says, go out there and make money selling this supplement. Think about that supply chain. Everybody's getting their piece, and almost literally there's not a lot of value being added throughout. And because it's so cutthroat, people are incentivized, unfortunately, to cut corners. So we did a study with black rice. So whole other story, but black rice, the thesis was it's a low glycemic index rice. We bought black rice from a reputable a natural store here and tested it, and come to find out it was really just white rice that had been dyed with elderberry.
Oh my.
Okay, and it came from China. Okay, so those are the kinds of things that you see. So what does that give us as an opportunity as pharmacists and innovators? Okay, so now you're talking to a guy who understands that from the field all the way to the patient. What if we stop that in that contract manufacturer in India? Don't put it in a bottle. Take that powder, ship that to ZüpMed. Okay, with all the controls, everything has gone to an FDA inspected facility, and now you ship that to Shannon at ZüpMed. And you take a 3D printer and you use a 3D printer to personalize your supplements for your patient.
And so that means a dose can be personalized. It means a lot of other things.
A lot of other things. Let's think about it from a nutrient depletion standpoint. We can sit here and name off 10 drugs that cause nutrients to be depleted from the body. Metformin and vitamin B12. We'll just use that as an example. Sure. And now, Shannon and Lloyd, you've got a patient on 5 different medications, and we know that there's a list of vitamins and minerals that are now going to be depleted in that patient, more than likely. Why don't you take that, do a personalized 3D printed supplement, and provide it to the patient? So what that does... Go ahead.
No. You're just talking about the 3D printing. You're talking about the formulation, right? Or are you talking about...
When you say 3D printer, you're not referring to something that takes a little plastic thing and makes your piece.
I'm talking about the technology exists today, Lloyd, for you to do everything with a 3D printer. Make troches, make films, make multi-layered dosage, make patches, make pill packs, and fill capsules, just like they do in a contract manufacturer. But now you have control over that. So what does that do? Remember I said there's all this, we use the term adulteration, which means just put bad stuff in it, prescription medications, or put in dust when there should be a natural product, right? Now you can't, the patient doesn't know when they buy a supplement because it's never been tested in that process. So they don't know if it has vitamin A, vitamin D, 9 times, because no one in that supply chain wants to take on that financial burden. Now let's collapse that that supply chain. Mm-hmm. And now you start to free up funds where, hey, why don't you have ingredient testing? And now the United States Pharmacopeia, they offer a testing program, but hardly anybody uses it because it's too expensive. Why is it too expensive? Because of the supply chain. So now let's shrink that. Let's put it in the hands of the pharmacist, the compounding pharmacist, okay? And that machine that I'm talking about is not something, this is not Back to the Future, this is not Star Wars. This exists today. You can put one on your countertop in your pharmacy today and do exactly what I'm talking about. And the last piece of that is it can double, right? So I'm talking about natural products and supplements because that's where you want to focus. But it can also double to compound specific personalized prescription medicines as well in novel dosage forms. You've got an elderly person with dysphagia, has difficulty swallowing. You've got a pediatric, a child patient that needs a special dosage form. Now you can do all those things with your provider that you're working with to really start to dial in what the right dose is and do it in a cost-effective manner. That, I think, is the sort of the future of pharmacy, and I see that as a way to provide tremendous revenue stream for those folks, pharmacy related, physician related too, potentially, depending on what their sort of office model is, to be able to bring that to their patients, have a better margin, and actually reduce the cost.
Yeah, I think what's interesting, and I think everybody understands the weight loss medicines and how the FDA approved medications, there's a cost to those. And I think if you haven't been living under a rock, you understand that utilizing compounding techniques when those agents were on the short list, that became a way for someone to personalize that medication, but also have a more affordable plan of their therapy. So I get that people can understand the concept that maybe personalized medicine could be compounded and in a more affordable way. What is interesting to me, and you are doing some of this now, and this brings back the focus of, an integrative approach to taking care of our patients at ZUP. And we're going to have opportunities when FDA-approved products are not viable or not fit that patient perfectly, to pair that with personalized supplementation that completes the picture, that is technologically here and now and very viable for patients to experience.
So does that exist right now?
It absolutely exists.
So let's take me, who
if you wish.
arguably is a pretty superb physical specimen, and I come and I say, and I'm just not feeling it. I'm just, name my problem, I've probably got it. So are you then able to, using a combination of traditional allopathic techniques of blood analysis and CTs and X-rays and whatever else we want to do, combine that with pharmacogenomics or genetic studies, and come up to me and say, you know what, you're anemic. We believe the reason for your anemia is that you may be having blood loss. We're going to send you to a gastroenterologist, a GI doctor, but in the meantime, we are going to formulate an iron supplement based on your particular needs and your particular genetics that is going to help you build up your blood. I just threw that out there. I'm just making this up as I go along. But does the technology exist right now to personalize those supplements? Maybe I need some folate. Maybe I have a mixed picture anemia. Maybe.
So here's the hand in glove part. You can actually have that testing done now, vitamin and mineral testing, right? And you're doing all sorts of it. You mentioned the Dutch test and these sorts of things. So pretty much if you can think about it, you can get it done now. So you can get that data. All this is with a call, right? I mean, so there are economics involved here, but this is all technically possible today for you to really dial in what's part of that whole interconnected system, what needs to be fixed. So let's take the GLP-1s. First, GLP-1s provide the recommended dose for a GLP-1.
I'm going to hold you just for a second. Do you want to just clarify what the GLP-1s are?
Oh, these are pharmacologic agents that are used in weight loss, and we've talked about the GLP-1s.
You want to throw some brand names out there so people know what we're talking about.
So brand names would be Ozempic, Wegovy, Zepbound, all of. I think because we've talked about these before, people are familiar with them.
Okay, so GLP-1s.
Right, so get your horn ready. So when you do the GLP-1, we slam on that ileal brake. So in other words, your gastrointestinal system stops. That's the purpose of the GLP-1 that's in the body. Okay. Now, it's not just tap the brakes. It's, when you slam on the brakes and the airbag comes out, you hit it so hard. Okay. So a recommended dose that was tested in clinical trials delivers 1,000 times the level of GLP-1 that your body is used to experiencing. Think about that for a second. 1,000 times. So when you go home tonight, when you get in your car, take your radio, turn it as loud as you can and drive home just like that. As loud as it'll go. Now, with a guy like yourself, a musician, that's probably not going to bother you, right? But most people, that would bother. And so what Shannon is saying is, yes, let's personalize that. Let's dial that back. And I don't really like the term microdosing, but a smaller dose that doesn't have to have that 1,000 times to have the effect. And then take that patient and say, we know when we slam on the brakes on that digestion system, that's going to do all sorts of bad things to our vitamin and mineral uptake. Not to mention, as you know, patients kind of forget to eat. Okay, so it's not just poor absorption because everything stops. They just don't eat right. And so there's so much opportunity there. But back to nutrition and supplements, here's where the muscle mass loss and the protein and all these things where you've got nutrition, you've got pharmacy, you've got medicine. All these things have to be put together in an integrative care model so that you can address these different things. Because that's what I was speaking with a gastroenterologist the other night. He said, we're going to stay in our lanes. He goes, I got a GLP-1 patient. I want you to manage that side effect profile on what it is that these patients need. So they need iron. They need other vitamins and minerals.
They need protein.
And they need protein. So how do you make sure that if they have taken that journey with a GLP-1 for reasons that, are their own, okay, and help them on that journey and say, we can help you manage the downstream. And a lot of that is through natural product intervention and individualized things you can do right there in the shop.
I just read a story over the weekend about those agents causing about 20% of patients who were receiving, and these were type 2 diabetes or patients with type 2 diabetes receiving a GLP-1 ended up with a vitamin D deficiency. And that was the major one at 6 months and a year. This is just a very real example of why it is so important for you to be monitored by someone who is looking for these things but can individualize your journey based upon what you need. And you mentioned an integrative model, and we have adopted that approach basically, number one, because it's very important, but number two, it's the right thing to do. And we have so many resources at our fingertips, and we take better care of patients because of that.
But it's not only care, it's also cost. Yeah. So think about that. Let's take the GLP-1s, and that's the article we shared over the week, right, about what's the latest research showing as far as what are the vitamin and mineral deficiencies. And let's just pick a number. Let's say it's 5 vitamins and minerals that are deficient. And so now you go up to the patient and say, you need this bottle, this bottle, this bottle, this bottle, this bottle. You got 5 bottles. Or you need this bottle for you, which contains all those ingredients.
All those 5. Yeah,
now you buy one supplement as opposed to 5 supplements. So there's a real cost here as well to the patient. I'm sorry, I interrupted you.
No. I mean, everything that we're touching on is unfortunately limited by the time that we have available. And that's the reality of this conversation. You're a fascinating man, and I mean, it's a privilege just to sit here with you. I think we could continue on this forever.
We could talk forever, but we have to sum it up for today's discussion.
I'd like to, if I may, add some small bit of value here. I'm wondering, what is the difference between a supplement and an FDA approved medication?
Going back,
because I'm still kind of there.
Two key things.
Okay,
2 key things.
Right.
First, what you can claim about a drug versus a supplement. Mm-hmm. So you'll see a supplement. It has to carry that disclaimer. This has not been approved by the FDA and not to be used to drug, right? All those action verbs. Okay. And then the other piece is the clinical trial part.
Right.
So that's where the supplement world lags way behind in general, because unfortunately most individuals so you go into medicine, you know what you're working with. Your healthcare, they went to pharmacy school, they went to medical school, they went to nursing school. I don't want to leave anybody out. They went to all health professions, right? Whether it's dentistry, veterinary, optom. Am I getting them all? Okay. Yeah. So all our fellow healthcare practitioners, you go into the supplement space and you look what the background is in the folks that are doing supplements. Mm-hmm. I don't have to say, right, full stop.
There may be a business person.
Okay, it's full stop. And so I think what I like to tell patients is, look, I love to cook. In fact, I brought y'all some low glycemic index cookies that are based upon the latest science. These are diabetic-friendly cookies that you can't tell the difference between a Nestle's Toll House cookie and this cookie. Okay. That's a conversation for another day. That's available to us today now, technology.
Did you say you brought some?
I did.
That's very nice.
Okay.
Thank you.
He's excited about that.
Cookies.
Right. And so that's the idea, is how do you bring those technologies to the patients?
Yeah.
And back to my educator. I've been an educator, so I taught in the military, running nuclear reactor, running submarine, all that, taught for 20-something years, teaching now. I always want to teach people about how to use their supplements, right? And so that's what's missing, I think, is in our healthcare system, And I don't care which discipline you're talking about, they're not taught hardly anything, if anything, about nutrition, about dietary supplements. And I'll give you an example, and this is fact, not braggadocious, but I have 2 doctorate degrees, and I do not have a single hour in the classroom related to nutrition or dietary supplements. Not 1 hour.
Right.
Okay, so that I think is a big gap, and while we have so much work to do to educate our colleagues, and so that's a guy like me as an entrepreneur and educator. How do you build a model where you encapsulate that and start to educate? And I'll leave this last thought in terms of the education piece. And I've shared some of these things with Shannon, some of the technology that we have now, Notebook LM by Google, for example, where you can take the primary and secondary literature and you can use artificial intelligence to create a podcast. And teach people about a complex topic in very real world language. That's one of the cool opportunities that's out there for us.
Kind of like without this, right?
Without that.
It makes it very easy.
You're going to miss my horn.
I love your horn. I love your horn.
You're going to miss
I
my
love your
horn.
horn.
You're
I love
making
your
fun
horn.
of my horn,
No,
but you're
I've
going
said
to
way
miss
too
my
much, so I'm going to stop there, but I hope I
No,
didn't.
I think it's absolutely fascinating. And just to summarize my question, the only thing I've contributed this entire conversation is it really seems to me that the problem with factually and realistically guiding patients in supplements is that because they have not gone through controlled trials, the information may be lacking, because I know there's some information out there, but the information may be lacking in being able to definitively say, oh, this will help you. But of course, we don't even do that with medications, right? Unless we are using pharmacogenomics. We used to say, let's try this blood pressure medicine.
Yeah, there's a big trial and error approach in some cases.
In some cases,
maybe
right?
Not cancer chemotherapy because they're pretty dialed in with that. But let's take hypertension, for example. Depression, anxiety, we do a trial and error approach to find something that works.
Historically we have, traditionally we
Yeah.
have, but now with pharmacogenomics and genetic studies, we're much tighter on that. And the problem with it, we can be much tighter on FDA approved medications, but it's difficult in supplements because the data is based largely on claims, unless there is years of experience out there that's been summarized. So is that not true? I mean, you're being quiet, which usually means I just said something stupid.
No. I think for the take home, because you were trying to summarize. So let me sort of help.
I was trying to summarize my one question. That's all I was trying to. I don't think you can summarize this conversation.
No, I think in a world today, if you are a patient today, you go and see a provider for a certain illness, you more than likely are going to get an FDA approved medication. Where Ryan and I have great interest is the ability to understand that FDA-approved medications may cause side effects, nutritional deficiencies that can be combated by utilizing technology, artificial intelligence, genetic studies, lab-based studies. And so, and of course, someone can buy a supplement off Amazon, as he suggested earlier. Our stance to this, though, is partner with your physician, partner with your pharmacist. Understand that individualized drug therapy, nutritional therapy, supplementation can be guided in a more intelligent way than just choosing a bottle off the shelf and believing the claim that's on the bottle.
Well, can I summarize it this way?
Yeah.
So I get asked all the time by people, patients, clients, whatever, and they say, what do you think about this supplement? Mm-hmm. And I always come back with, you're asking me the wrong question.
What is the question that we should be asking?
Right. So I said, you're asking me the wrong question. They give me this perplexed look, and I say, what are you trying to accomplish? Mm-hmm. Because at the end of the day, they're not coming there because of a supplement. They're coming there because they want to change some function in the body to improve X. And so I think that's where we have the real opportunity if you understand how these different functions, how the liver interacts with the thyroid, that interacts with hormone production, but outside of thyroid, and infection, inflammation. You understand how those things fit together, then you can step back and say, okay, I understand what you're trying to do. Here's how we'll go about solving that problem. So cholesterol, we know, is impacted by 6, 7, 8 different pathways. And when we give a patient a statin and they don't respond, okay, well, that's because there are probably 5 or 6 other things that are contributing to that poor cholesterol, right? I guess I'm going to use it, high cholesterol. I abhor that term because there's no such thing as high cholesterol. We'll talk why I think that next time. But I think that's where you have the opportunity. If you understand how these things fit together, you get out of your silo and say, that's the cardiologist, that's the gastroenterologist, that's the infection person. We become so specialized. And this has been really eye-opening to me, even in the world of pharmacy, is we become so specialized that we've forgotten what our roots are. And we can't do systems pharmacology. We can't look at the patient from an integrative standpoint because we're specialists. Yeah. Which is, I think, the worst thing.
It's a detriment.
It's a detriment. Now, don't get me wrong. When I need a gastroenterologist, I need a gastroenterologist, right? But 9 times out of 10, that's a high estimate, you need someone who understands you as a human and integrative and can connect the dots between the different organ systems. So I was in Meridian, Mississippi earlier this week, sitting down with a female physician, been practicing for 27 years, okay? Halfway through my spiel, she looked at me and she goes, I want to learn from you. Okay? And that said nothing about me. Absolutely nothing about me. That said everything about her and what she's able to learn in a practice where she's seeing 70 patients a day. She can't keep up. What's the latest? It's just impossible what we're asking physicians and healthcare practitioners to do in this world. And so I think that's the other part of the integrative care. That's where pharmacists and other healthcare practitioners can help augment what you bring to the table as a physician, what you bring to the table as a nurse. That's what I'm focused on building, but with an eye toward the economic model, right, in the future. That's what, so this will be my 4th career starting this clinic, okay? I'm being literal, right, between the military, everything else. That's what I want to do with the time I have left on this earth.
Well, we'd love to work with you. Bring it on.
Thanks, Ryan,
and
so
bring
much.
that machine, too, that makes all the medicine stuff.
We're going to have a conversation.
Okay. Well, thanks, everybody. I'm rarely speechless.
I know, I know. If we can help you in any way, please just give us a call. We're at ZüpMed, 901-701-7010.
What a pleasure.
Thank you very much, guys. Enjoyed it.
Be safe out there.